in from the lobby. It will take just a moment. And so as people are joining in from the lobby, as usual, good afternoon, everyone. Thank you all for waiting. We are letting everybody in from the lobby right now, so please give us a moment or so for that to occur. It usually does take a minute or two. In the meanwhile, my name is Dominic Zerlo, and I'm the Center Director for Medical Cannabis and Psilocybin at the Department of Health. And the department is just here, and our program is just here to help and assist with the committee. And so we have several folks here who will be doing just that. This is the Education and Training Committee with Brenda Burgard, who is the chair. And so with that, Brenda, I will turn it on over to you. Oh, sorry, my apologies, Brenda. One last item, almost forgot. Just as a reminder to everybody that because this is a public meeting and because we do post these up onto the website, please keep language appropriate. And for those who had not been on some of the earlier meetings, the reason we do not have everybody on with face, but just a couple of people at any given time is because when we have so many people in meetings, and if they are on both visually as well as audible, then what ends up happening is it takes up so much bandwidth. Some of our folks who are in areas where it's more rural or frontier areas tend to drop off the call due to the internet connection a little more often. So we try to keep the bandwidth a little lower. And so that's the reason we just don't have everybody all on camera. But we appreciate it. Thank you all very much. And Brenda, back to you. Sorry about that.
Oh, that's quite all right. All right. Well, thank you everyone for coming. I really appreciate you being here. I know there's a lot of people out there that are very knowledgeable about education and training, and this is what this is all about. And if you've been to other meetings, you'll notice there's a little bit of overlap here and there. There is going to be some of that. But for right now, we're going to try to stick to the education and training part of this second meeting. And if you wanted to, Jorge, if you could bring up the agenda on the PowerPoint.
On your PowerPoint? Is that what you're asking? Okay.
Yeah.
Let's see.
And while we're doing this, if anybody wants to introduce themselves, they can do so right now. Just please raise your hand.
All right, and just a reminder to raise your hand there on Teams. There's a raise icon with a little hand icon up at the top left or center-ish part of the screen. If you'd like to hit that, we just posted instructions in the chat for that as well. All right, I see we have Harvey King. Your hand is up, and I have enabled your mic. You can unmute when ready.
Hi, I hope everybody's doing well. I was in the Improvement Research Committee meeting this morning, newly just joining these meetings, and as a hospice nurse, interested in end-of-life use of psilocybin. And so excited to start to be a part of all of this. Thanks.
Awesome, thank you. And next we've got James Brown. James, your mic is enabled. You can unmute when ready.
Afternoon, Brenda, and thank you again for chairing this awesome committee. I do appreciate you and all your efforts. So amazing. Everybody, my name is James Brown. Earlier, I'm a PharmD from New Mexico. I'm psychedelic facilitator trained in psilocybin. Very excited to be part of this. Thank you again.
All right, thank you, James. Again, for anybody who'd like to introduce themselves, the instructions are in the chat, and the raise icon is towards the center left kind of part of the top pane there. I see Gregory Evans has his hand up. And Greg, your mic is enabled. You can unmute when ready.
Thank you. I think everyone's just getting settled. There's a lot of people in here that should be introducing. My name is Gregory Evans. I am an independent researcher and home mycologist with no affiliations. I'm a Santa Fe resident, and my intention here is to support the program's development through committee recommendations, which are aligned with emerging research and best practices.
Awesome. Thank you, Gregory. And also, if you'd like to introduce yourselves in the chat, instead of raising your hand and doing so audibly, you can enter in any information you'd like in the chat as well. All right, not seeing any more hands raised right now. Brenda, if you want to go over the agenda, and if anyone wants to introduce themselves later, if they have comments, if you could just do so before contributing to conversation. Thanks.
All right, thank you. All righty, so this is our second meeting, and I just wanted to put up a short little PowerPoint here about what we need to cover. And so today's agenda will be looking over reciprocity, education in the curriculum, what the curriculum is going to have in it that is specific to New Mexico and New Mexico history. Cost, training, and education, which I don't really have a costs of what this is going to be or what will be allocated. So, there's a lot of questions that need to be answered or will be coming along as time goes on. So let's see, let's go to the next slide. Okay, so I want to open this up to everybody and I'll go ahead and read this and then have some comments about this. So I wanted to target the reciprocity and recognition of the prior training, because those of us have been in training from other states like Oregon and Colorado and other places. We want to make sure that we're having enough education to bring here into New Mexico. However, a lot of us have spent a lot of time and money learning how to do this very specific training. And so when we've done all of that, we want to see if we can get going with what we know already. And so we want to build a framework that supports these pathways for all of us clinicians and medical providers and spiritual care professionals prior to psychedelic related education or training completed in other jurisdictions. So what I think we really need to look at here is documentation for this, because all of us have a variety of different types of documentation, syllabus that's very, very heavy in information and practicum. And so before New Mexico started taking on this wonderful practice, we had to go elsewhere to learn how to do this. So I'm just wondering how we are going to do this with the Department of Health. And so some of us have certification or transcripts or both. Some of us have some documentation of some sort that could qualify for proof of reciprocity. And so I would like to know how many of you out there are kind of in between, haven't really finished any certification yet, but are in the process somewhere else learning how to do this type of training. Just raise your hands. so there's a few people out there. So what does that mean? So we're going to start to get this together, basically. What does this mean? Because I know some people, we can't leave some people out, we can't have exceptions, but then again, we have to understand and bring this all together so we're able to have people come in and start doing this work. So let's see. So I was talking to Dominic earlier about, what is licensing going to be? And so that's going to be, I think, a totally different department. For those of us that are practitioners, therapists, doctors, nurse practitioners, we already have licenses. So what does that look like for us? So I want to pose a question to everyone out there. What would you like to see as far as your training goes? What would you like to have New Mexico have in their training program for reciprocity?
All right, I see Ann Metz's hand up. Ann, I have just allowed your mic. You can unmute when ready.
Hi, my name's Ann Metz. I'm a licensed professional counselor and natural medicine facilitator. I'm trained in Colorado. I live in Taos County, and I'm also the director of Fluence's clinical natural medicine facilitation training program in Colorado. And so I think, wearing the hat as a training director, I think that having New Mexico's program is largely reflect what the other states have required in terms of training, I think is practical and also in the best interest of students to give them more options for training programs. And in terms of like license reciprocity, I think if you're licensed in Oregon or Colorado to provide these services, I think that would be a really nice, just to be able to have license portability in New Mexico.
Thank you, Ann. And I think that's a really important topic here is people who have been licensed in other states, getting licensed here in New Mexico, what is that going to look like? And unfortunately, I don't have that information, but I think that we'll be able to bring that into New Mexico for training. And so that brings me into the next slide. Let's see what the next slide is. Okay. Should people be grandfathered in? In other words, if you've been working in other states, like Anne has, and lives in Taos, yeah, you're definitely wearing two hats here. And so I think that bringing people in that are already doing the training and the education should be able to practice here in New Mexico. The other thing I was thinking of, and this was what I was trying to propose here, is that people who already have certification and training and are not here, well, trained here in New Mexico, because we're just starting, why not have like a 6 to 8 hour review of additional training here for New Mexico? So to meet the qualifications here, so we're not getting bogged down with hours of training, trying to do this. And also too, right before I had this meeting, I'm like going, well, maybe also too, once we start getting very close to training and getting this rolling like weeks before, if any of us who are certified need extra practicum, and that would just be maybe another 6-hour day or something like that to get your feet wet, and that would be just an extra added, bonus for your education here in New Mexico. But however, if you're already here in New Mexico, I wanted to kind of keep that as an add-on, just if you needed a refresher. For instance, if been certified like years ago, but have not been able to practice, or for protection of your own license, kind of shelved it for a while. Maybe doing that with all of the other education and training that you've had. And I think maybe having that while this program is starting to roll out, just as a refresher. But I think that, so who out there feels that this is fair to have something like this, additional training? Just raise your hands. Yeah. Okay. Anybody opposed to anything like this? Do you think we need less or more hours?
I think Lisa Ginsburg had her hand up prior to that. Just gonna allow her mic. Lisa, your mic is enabled. You can speak when ready.
Hi, my name is Lisa. I'm the founder of Changa Institute. We are in Oregon and Colorado to provide certification training in psilocybin facilitation. And from our experience, I think it would be really helpful to have clear guidelines on which institutions would you count as accredited programs, because what we experience, people submitting the application saying, oh, well, I took this course somewhere and it was just one person creating a course. There's no accreditation or structure in the course. Unfortunately, for our program specifically, we cannot accept that. We do accept people that are transferring from different accredited schools and programs that not even accredited, like California Institute of Integral Studies, MAPS, and so on, that we can accredit and count towards a program. But I think it would be really helpful for training programs to have clear guidelines from you guys on which programs and certifications would be counted towards the transfer credits. And in terms of the hours, I really appreciate the last question. I think depending, because, for example, Oregon's training requirements 120 hours, 25 hours now. In Colorado is 150 hours. People who transferring from Oregon to Colorado would have to complete additional modules on ethics, like additional at least 25 hours plus. We also have to cover the regulations and rules. So I would think about that, because sometimes, yes, someone can be accredited through CIS or different programs that have outstanding curriculum, but it might miss the most important part of rules and regulations that New Mexico requires. And I think that is important for people to cover, to even protect themselves as practitioners, to be aware of the rules and regulations. So I think it's worth to understand how long the program is and what would be the requirement for those hours. And I think it would require more than 6 hours, in my opinion.
Yeah, well, thank you, Lisa, for that, because that was on one of my slides as well, because I did talk to Intertrek last week, and the 150 hours and the 120 hours, that would be like start to finish. And that would be, a program for people that are just starting with psilocybin. Of course, there is a big list of accredited institutions and programs out there, like MAPS, and that would be up to the Department of Health, because there is a long list of accreditation through these institutions. And yes, when I was talking to Intertrek, Lisa over there, we were talking about how some people, they have a lot of experience, but they don't have the ethics. They don't have the other training. And we've got to remember this is a medical program, and that this is basically for people who, you know, have already have a license. That's what the reciprocity is all about. So yeah, I really appreciate you your input on this. And 6 to 8 hours, I think, covering the topics. And I think if we move to the next slide, I think it's in the next slide, I put that in, creating a curriculum for education in New Mexico. Well, maybe we could go to the next slide. Let's see what I have there. Okay, insurance liability, training hours, licenses, billing. Okay, let's go back to the previous slide. And we'll just keep it there for now. So yeah, what I would like to see is a list of the institutions, the education programs and training that do have all of the requirements for our training here in New Mexico. And so that leads me into this. You know, what is our curriculum going to look like? There's a lot of different curriculums out there. There are a lot of hours put into this. And I think we could go ahead and bring up the document at this point. We can, Jorge. And while we're doing that, let's see.
Looks like next in line with their hand up, we've got Jen Clemente. I'm going to allow your mic. Jen, your mic is enabled. You can talk when ready.
Okay, yeah, I didn't really have a question per se. I just had raised my hand, I think, answering one of the questions, but let me kind of scroll back here. No, there's nothing I haven't mentioned that others haven't, so I don't need to ask a question now.
All righty. Let's see. How far back are we on the chat here? So let's see. Okay. So what we could do is here, let's see if we can increase the size of the document here, Jorge, if you can. Okay. And let's go ahead and
is that good enough, or does that get enough?
A little bit more.
Larger?
A little bit more.
Tell me when.
Okay, that's good. That's good.
Okay.
Okay. So yes, I didn't get a so hello, Tom Eckert. You were mentioned by Lisa there at Intertrek and for the training program there, and she was kind enough to show me the curriculum there. Let's go ahead and scroll down a little bit. And so, yeah, let's stop right here. So what I had in mind, let's just back up a little bit up to the, okay, yeah, it's kind of in between here. Okay, let's guiding principles. Okay, so for the first part of, you know, the curriculum here, I think the framework basically here is, you know, first safety and ethics, you know, prioritizing you know, physical, psychological, cultural, spiritual, and moral safety of people and people that we're working with. The equity and access, reducing barriers for historically marginal communities. And let's keep scrolling up a little bit. Okay. Cultural humanity and respect, honoring indigenous knowledge and sovereignty and lineage-based practices and diverse spiritual traditions. 4 is trauma-informed care, recognizing the prevalence of trauma and avoiding reharm. 5, interdisciplinary collaboration, valuing distinct clinical, spiritual, and cultural community roles while fostering sharing and understanding, evidence-informed based practices, integrating research and data, lived experience and clinical wisdom, and pastoral and spiritual care frameworks. And number 7, scope of practice and clarity and clear boundaries based on licensure, ordination, and certification and role. And let's just scroll down a little bit more. So, and keep going to learning objectives. Let's go there. Okay, let's just stop right there for a moment. So let's take a look at all of the different things that we want to try to bring into the curriculum. And we're going to have to start writing one up. We're going to have to start bringing in materials and education. But in the same time, we can look at what others have done, you know, other programs that are out there right now that can start to, we could start to bring into New Mexico. So let's see, of course, we're going to be the learning objectives, describing the historical, cultural, and spiritual contemporary use of psilocybin or psilocin, because I think this is going to change a little bit because of the, we're really looking at psilocin as the active medicine. And so that there's language that is going to be changing. You know, in the curriculum, understanding basic neurobiological and psychological mechanisms of action, identifying indications and contraindications and risk factors, explain ethical considerations, informed consent, and power dynamics. Okay, good. Scroll down a little bit more. Recognize the role of set and setting, preparation, ritual, and integration. Understand legal and regulatory frameworks relevant to their jurisdiction and role. So that one is really important to us here in New Mexico. We want to be able to fit this within our legal system here and keep it the way it needs to be. So in this curriculum, and we could go on and on and on about what we need to have here, but let's scroll down to these core educational domains. Thank you. So when I was saying like between 6 and 8 hours, I was thinking these core educational domains can be at least 1 or 2 hours each to cover each and every one of these categories in the education process. So I think that those of us who are certified or have some kind of documentation, bona fide documentation in our healthcare that's recognized in the Department of Health, I think having a review of these particular education domains, so history and culture context, neuroscience and psychology, mental health, spiritual care and applications, if we could keep scrolling down, ethics, consent, and power dynamics, we could still keep scrolling, legal and regulatory overviews, and then we can start to maybe incorporate what other programs have into our program. So I think that those of you who are out there educating right now, if you do have a curriculum that you're presently using, that creating a document or a curriculum that you would see that could incorporate New Mexico's culture and other domains here would be really fabulous. And I think presenting that into the next meeting or the next 2 other meetings would be really good, because then we could get on track on things that we could be missing in this document. Change the language if we need to, add or edit some of this in this document. And then we could take a look at some of these curriculums that are out there. So my question to everyone is that what would be the best thing for us here in New Mexico to learn from all of these other programs?
All right, and looks like Lisa Ginsburg has her hand up. Let's see, Lisa, I have enabled your mic. You can talk when ready.
Thank you. From our experience, we see a tremendous need for emphasis on ethics. We have, most of our clients and students have a medical license, either coming from nurse background or therapist, psychiatry. However, the ethics that applicable for psychedelic therapy is significantly different from standard ethics. There is a notion of shared altered experiences and other states that are not covered in standard practice. Yes, we talk about different types of ethical approaches, but I think that requires minimum 2 hours of going over ethics that specifically applicable for psychedelic assisted therapy. And I think that's one of the few points that I wanted to highlight. And in general, I'm still talking about the additional hours for someone who's transferring their certification. I would go towards increasing the requirements, because for ethics, we need at least 2 hours plus going over the rules and regulations. We're looking at minimum 10 hours, if not more.
Yes, I think ethics is one of the biggest ones that need to go over. And yes, Lisa, I think you are spot on with the ethics that concerns psychedelics, because it is different, and there are more additional things that need to be covered ethically when it comes to psychedelics, like, for instance, consent for touch. If someone is not feeling heard, or for some reason their identity has been breached, there are a lot of things that need to be covered here. I think there are other ethical issues as well that primarily, like, I'm a telehealth clinician, and there's different kinds of ethics that kind of are there, because people can walk in the room, there's it could easily be a breach of confidentiality there. So those things, I think, is very, very important. The one thing that I'm very concerned about for us here in New Mexico is that we don't have time. And I think as far as training and education goes, we're in urgency. We have to really get a really good, robust curriculum down that will help all of us. And I think that the additional training for those who are already certified, I think that's a very, very good point. Now, I'm sorry I didn't get to read everyone's chat. I can't do two things at one time. So I just wanted to say what Kate Hawk here has. She says these categories make sense. Number one. Number two, some of us, based on previous training and experience, qualify for a 25-hour version of Colorado's 150-hour training that covered ethics, and Colorado's program. This was helpful even for very experienced practitioners. And two, whenever the initial qualifications are, I hope we can have provisions in our system for ongoing support after licensing. I love this because we will have to have ongoing education here, because it's not going to be one and done and that's it. The more this moves on and we're creating this, and I've said this before, we're putting the plane together as we're flying it. We want to be able to have this in place before we start going. But like I said before, we're going to be pressed for time. And so what I would like to see is all of this that are certified. We already have a program here, and maybe 25 hours would be adequate for all of us that are already certified. And like I said before, had an add-on for additional training would be great for all of us, because we want to be able to satisfy what the Department of Health has for us. Now, yeah, go ahead.
I'm sorry, I think my mic is still on, and I just want to, I think that's great. 25 hours sounds really ideal. And a few other things that I looked at the core educational domains, which is well structured. A few things that maybe, because I cannot see a full document, missing is the dosage. And since New Mexico does not have a constraint on which psilocybin strain is allowed, and you guys sounds like will be allowing all type of psilocybin, it is important to also cover, because different type of psilocybin mushrooms have different effect, and I think that's something that needs to be covered as well, even in an overview, including the age. We see a lot in practice with a older population. It takes time to people process the psilocybin and feel the effect, and they tend to have deeper journeys and more physically adverse reactions. So I think that's important also to cover, including non-directive facilitation, which also I have not seen in the core educational domains. But maybe it's there. It's just I have a limited view of it.
Yeah, yeah. This is kind of a short little like screen here. Yeah, I think that what was it? What you were saying about dosing and all of that. Well, we do have a dosing committee that is, and also too, the propagation committee is also talking about, dosing types of mushrooms, what will be allowed, what practitioners especially need to be very educated on the different types that are going to be used in this and how it will be used. So we will, other committees are working on that, and there is overlap in a lot of our committees because of the education part is part of that. Also too, it's kind of, I try to attend as many meetings as I can, but I know the dosage is going to be a big one for educating us providers. So yes, that's I agree with you there. It does have to be one of those things that we really need to be well versed on.
All right. And next with their hand up looks like Patricia. Patricia, I have enabled your mic. You can talk when ready.
Hi, thank you so much, Brenda. Thank you for holding space with us. I think my hand got mixed up in the last time we raised our hand, so my input is on. It's like 5 slides ago, but I don't know if they're able to. But it was like I think.
Oh, you're breaking up.
For seconds. Oh, can you hear me?
Yeah, you'll have to repeat what you said.
Okay.
I'm sorry.
That's okay. Back to, I think, your second slide where you had the slide regarding submitting prior training. So I was kind of curious about that because we've had some, some educators on this call. And I know I'm here in New Mexico. I'm a spiritual healer. I own Invocation Healing Arts, and I've been training for the last 4 years to serve here in our state. But I specifically chose not to do a certification out of state, knowing that we didn't know our protocol here. I do have teachers who can provide like didactic trainings to provide like documentation of that. So I was just curious if your slide, if that's kind of what you meant by that slide, or if that was for...
Yeah.
Okay.
Well, so if you, for the sake of saying this, in the healing arts, basically, or alternative type of, not, medical or anything like that. I see that as also too, if you've been certified in something that should be under the umbrella of qualifications. So if we scroll down this document, let's see, keep going. All the way down. It's in reciprocity. It's the last page. Okay, hold it right there. So, documentation for reciprocity review umbrella approved. So if you have certification of completion or transcripts from, other places that New Mexico will approve of that accreditation or that certification, then you'll be under that umbrella of reciprocity. Now, let's see, let me look at the chat here for just a moment. So Kaina Mackenzie, I hope I said your name right. She said, in the absence of a national certified body for the education assessment of facilitators, rather than accepting what other states have accepted, it may be wise to screen and list specific programs the state of New Mexico find best serves its unique communities, as well as programs that cover contemporary needs of the state. She also says that look at what has worked well in Colorado, Oregon, and what hasn't, to grow and evolve from there. And so that kind of is in line with what we're talking about here. Like what is the Department of Health going to accept and what are they going to accept? So it's really up to them. I mean, we can go ahead and propose what we want in this document and other meetings, like with dosing and all of that. That's why it's really important for us to kind of come together and work with this. However, if you, like, for instance, if you are a somatic healer and you have gone through a program with working somatically with psychedelics, it should be under the umbrella of alternative types of training. However, it has to meet qualifications too that the DOH is going to want to have as far as licensing goes in practice. So it's really up to them, but I myself would love to include everyone that has been trained in psychedelics that have had ethics, for instance, that has had classes in our historical culture here in New Mexico. So, okay. Who else is up there?
Brenda, can I just say one more thing?
Yes. Yeah, go ahead.
Oh, I just wanted to say I also agree with your suggestion, and that I think it was that same slide regarding having, I don't know whether you call it a la carte training or whatever that is, for folks who, like you said, already have a lot of training, but maybe there's like certain topics to brush up on, or even certain things that are specific to like our communities here in New Mexico, or even like the 4 specific conditions that were approved. So yeah, I like that idea. Thank you.
Yeah, and I like what I think it was Lisa said earlier, having like 25 hours. And like let's say you're deficient in one of the core curriculums there. And you say, I really need to brush up on my ethics, or I really need to brush up on having a practicum, or maybe there's been, more included in the history of New Mexico. Maybe there was something in a prior curriculum that didn't make it into a present curriculum. So, and having this ongoing education, that's why in licensing, you have to get your license every 2 years and have at least 12 hours of ethics. And why couldn't psychedelic ethics be part of the 12, CEUs that you need for that? And that's just an example. I think that would be very helpful for a lot of us that maybe we missed something, or just to cover our deficiencies in our education and training. I think that would be wonderful. And also too, people who moved here from other states that are certified and have a need to, hey, maybe I should take these extra add-on classes or this curriculum so I can, really serve the community here in New Mexico. All right, anyone else?
All right, next with their hand up, we've got Tom Eckert. Tom, I have enabled your mic. You can talk when ready. Or unmute when ready, sorry. And just as a reminder, the mic icon up at the top, right part of the screen. There you go.
Thank you. I found it. Yeah, thanks for having us. My name's Tom, Executive Director at Intertrek and founder of Intertrek. Also was the chair of the Oregon board back in the day when it was just getting started. And I was also the kind of architect of the Oregon campaign. So I've seen things unfold, and what's kind of important to me is standardization of training to some degree, such that the core of training is well understood. I mean, it's in regulatory frames in Oregon and New Mexico, and have been looked at in different ways for some time. And you're bringing attention to, okay, how do you customize for New Mexico? So I think there's kind of this unfolding piece of like identifying core training, which there's a lot of clarity there, just kind of A to Z what that looks like in regs, and then thinking about what your state is kind of kind of uniquely looking at. And with New Mexico, you have qualifying conditions, so it seems like there's particular attention to those conditions. Those could be part of gap education, I guess you could say. So what I'm getting at is if you have core education, there's lots of approved programs in Oregon, Colorado. There's also programs that just have commensurate, check all those boxes. You figure out who those programs are, and then you figure out what's unique to New Mexico. So you have whatever kind of pieces you want to put in there. And I just hope that kind of unfolds in a kind of a simplified, standardized way. I think it might be challenging I'm trying to get clear on how you're thinking about evaluating where folks are at in that process, because I'm hearing that with credentials, there's a potential for picking up on this education in different places, such that there's, kind of skipping through some of the elements based on credentialing. I'm not sure if I have that clear or not. But I would suggest that the less of that, the better. I think that, psychedelic training is pretty unique. We have a lot of credentialed folks in our program, and we rarely feel like, oh, they already had this piece and don't need to kind of do it, although there is some of that. So yeah, I'm thinking in those terms, like it seems to me that the core education piece is fairly clear and is well laid out in a lot of different ways.
Well, thank you, Tom, for your input, because I was looking at your curriculum and a couple of other ones as well, and I like to lean into like simple is the best way to do things, because I think once you start putting more things in there, the more complicated it gets. I just wanted to read some things in the chat real quick before we take some more people that have their hands raised. Let's see. Jen Clementi says ongoing support for me would look like opportunities to practice sitting, role playing, simulation, and group support to discuss various scenarios that come up. That's a great one. Yes, I think practicum is a really good way to learn. And let's see, Michelle says perhaps just like teaching licensed practitioners are required to complete X number of CEUs to stay current and relevant. That's great. I like that as well. Gregory says we're starting with reciprocity. That's the wrong starting point. Before we talk about reciprocity transfer or amending training, we need to define what New Mexico's program actually requires. That baseline doesn't exist yet. You can't evaluate what transfers until you know what it's transferring into. New Mexico is doing something different. Oregon and Colorado are not our model. The structure we build here needs to reflect that. I think we need role-specific requirements before anything else. Each role has a distinct scope and a distinct risk profile. Absolutely. Referring clinician screening, competency, indications, knowledge, informed consent, high stakes on patient selection. Yes, administration clinicians, the core practitioner role, heaviest training requirements, sessions management, safety response, pharmacology, integration therapists, pre and post, preparation, integration frameworks, existing licensure probably carries the most transfer value here. And support personnel. Do we have sitters, monitors? If yes, what's the minimum competency floor? This needs a decision, not an assumption. On credentialing question, I don't think formal education equates capacity. I'm also not suggesting we disregard educational institutions. The real question is whether the credential maps to the competency we're actually requiring. Define the competency domains first, then ask what pathways demonstrate them. Formal education, supervision hours, demonstrated practice, lived experience, don't use a degree as proxy for readiness. And once New Mexico requirements are defined, reciprocity becomes a tractable question. Does the applicant's prior training meet our standards? What carries over? What needs a bridge? Until we answer those, reciprocity decisions are circular. And yes, this document does include a lot of what you stated here. The reason why I'm starting with reciprocity here is because we don't have a lot of time, and we have to start with people who are already trained. And what will that look like? And that's why I'm starting here, because our first meeting was going over a lot of what you had mentioned. And so this is a medical program. So starting off with medical providers right now is probably going to be the first thing. And the other certifications will be coming in as well. And also too, what qualifies people? So that's up to the Department of Health to see which programs are going to be implemented into the Department of Health, and what they see is going to be the right avenue to go down in. Let's see, before I read any more chat, let's see, who has their hand raised? Gregory?
Yeah, and that's actually a good time because Greg's the next hand up, and I think your mic is still enabled, Greg, so you can unmute when ready.
Hey, cool. Yeah, just to shape all that wall of text I dumped on you.
That's great.
I'm thinking about this from a product development perspective. I'm not an educator, and I'm not like a doctor, but I am an expert in putting planes together while they are in the air. I have done this in several types of ways throughout my life. So if we're looking at building a program, we need to get to the requirements before we start building. And so as soon as you have all of those requirements in place, then the reciprocity just falls in. So we require that you have this qualification, and I can pull this qualification out of my pocket and show you, hey, I have this widget, and now we can move forward. But wait, I'm missing one thing. How do we fulfill the need of educating and qualifying that person to fit the requirements and get this moving super fast? Because we have people in the room right here who can do all of the things that we need today. It's just a matter of defining those requirements before we start like circular, going through the circular logic of, well, how do we do reciprocity before we know what we're putting that into, I guess.
Okay. Yeah. So
one other thing, sorry.
Yeah, go ahead. No,
when it comes to the dosage conversation, I would be more than happy to write that section for you.
Okay. And I think you've been going to the dosing meetings, and haven't you?
Yeah, and beyond that, like I've already got like I've been working on understanding analytics and dosage for years, and I have the workings of publications in place and a deep understanding of how unique chemotypes affect experience and how to analyze those and how to communicate that in a very simple way. But yeah, that's down the road.
Okay. Thank you. Thank you for that, Greg. Okay, so let's scroll up to the top. Let's start from the beginning here, because just so that doesn't confuse people anymore. So at least get the purpose of this document right there, and if we could scroll up and see that. So yes, I think bringing all of that in, we're I think the dosing and the education part's going to be a big one, because maybe some clinicians won't feel comfortable with that, and then what if we didn't do them a really good service of training them and feeling comfortable with dosing? So that has a lot to do with the training process, and how much do you dose somebody, and all of the contraindications that may be falling through the cracks that people really need to learn and be trained with. Yeah, absolutely. Let's see, I will read another chat here. It says from Catherine, one thing that we will be doing different from the other states is practicum. This will provide a level of training that doesn't exist in Colorado and otherwise. I believe in other states they are too heavy on lecture, and we can require less, but also require practicum, which gives much more overall training than just lectures. Let's see, I'll just read a couple more, and then we'll go to, I guess, James here. I think he's next. Also, the core educational domains would cover integration. I think I might have that in there in this document. I'm glad there was mention of dosage related to age. I don't recall factors of working with older patients being emphasized in any of my previous trainings, except for end-of-life care. Working with older population is significant specialty, something that everyone should have awareness of. And yes, I'm a senior, by the way. That never occurred to me either. I think that's a very important part, and I think that should be looked at as well, and brought into the curriculum. Excuse me. Okay, I'll just hold it right here. Okay, I think James Brown is next. Is James next?
Whoops. Yes. Okay, I have enabled your mic, James.
Brenda and everyone, my thought on this too, going back to what was said earlier, standardization. As we're the third state in a unique position, right now it's very key that we standardize our training with some of the other standardizations that's already going on with the curriculum that's currently available. So if we say that Oregon's 120 and they're growing every year, they keep passing more and more hours, and we say Colorado's 150. In order to do that reciprocity, we have to minimally say that we're going to have around 120, 150 or more. And so just a thought there, right? Just kind of standardize. I really like that idea because there is no other governing board out there, but there will be. And when that governing board comes, how are they going to look at our program? Or are we going to be the people that help set those trends and help set that board, which I'm hoping happens for New Mexico? And so,
absolutely, yeah. James, I think you're, I think you're, you're really on that, and I think that there has to be a standardization of accreditation for this because, like, I'm MAPS trained, and I think that was, geez, I counted as months. It was like 6-7 months that the training was there, and so why we shouldn't really, I really I'm hearing what you're saying. This program should be really robust, but it shouldn't be watered down either, and that this should incorporate a lot of the standards that we're seeing that other states are doing, other institutions are incorporating, and that we should also have that as well. If we, because a lot of these programs are specially trained, we have these trainings to have this so we can move it along, that we need to do this like now. However, I think we only have till December, so to get this rolled out in a manner that we are doing it safely and ethically and incorporating, our culture. And also, the dosing part of it is, I think, one of the main things that makes a lot of us nervous because, of course, we want to have something there, a standard to go by, that we're giving, the medicine in a proper and correct way. Okay, who else do we have here?
Looks like next we have Chris Caldwell, and I have enabled your mic.
Yeah, hi everyone. Nice to be here. I want to sort of echo what I heard Greg say, because New Mexico is not like Colorado or Oregon. You are a medical model, and Brenda just said it yourself a little bit ago. You're going to have medical clinicians, mental health clinicians needing to be trained. When I build a course for physicians, it's very different than building a course that's more that's for more disciplines. And so I strongly recommend, you step back, and like what Greg said, what are the requirements here and who will you be training, has to be looked at first. I mean, for example, when you have a non-medical model, preparation and integration does not encompass anything taking into account, let's say, a licensed social worker. Here, you should be. It's not totally non-directive. You're talking about people who can practice psychotherapy, and they should be practicing psychotherapy. If a clinical chaplain becomes part of that team, and then, their training will include their license work, preparation and integration. So I think you're talking about a very, very different type of training, quite frankly. I like the core. Any of the non-medical models can clearly deliver on the core and much of the skills. What I saw was missing in part 2 skills was like self-care and safety, by the way. And I think there should be a module on interdisciplinary collaboration as well. But I'd be looking at a Pratty group, or I'd be looking at Polaris, or anybody who's been training physicians and clinicians.
Well, thank you for that. I think, yeah, we do have to kind of stay focused on the medical model here. Later on, anyone who is practicing in healing arts, per se, is, they also too need to be educated. I think it might have been, I guess, Lita Fatemi in our last meeting. I think it was her that said that have the training that everybody can have. But as you're saying, it's like the medical model is different for people who don't have the medical training. So yeah, you could do that. However, and it could be cost effective. However, I see it as a little different, and that there has to be, maybe, now I could be wrong, have 2 different types of education with that. So, like you were saying, if a like, let's say a priest wanted to do this, yes, he has credentials and licensed or whatever, and it takes this class. I don't know. I really, now that I'm kind of talking through my head about it, I really don't know personally if the medical model or the medical training would encompass that. So yeah, if I can have other people talk about that.
Well, I would like to finish my thought, because maybe I should not have said anything about a clinical chaplain, because you went down a totally different path than what I was talking about. And basically you keep talking about there's no time. Well, I think, you need to build the right program to deliver the best service. And if you need to push back the start of this program, then push back the start of this program, or limit its rollout. That was arbitrary. You started first with December 31st, 2027, and then whomever decided they were going to push it back or push it up to 2026, that was arbitrary. And so you need a good, strong program. Again, you're a medical model. You're not a non-medical model. All right, I'm done. Thank you.
Yeah, thank you. Thank you. All right. Let's see. Okay. All right. So, Ellen said there is no specific number of didactic hours needed. We need to look at competency, not number of hours. Let's see. And it's in students' best interest to have standardization. It may also allow them to also work with FDA-approved psychedelics if we align with other states. Eileen said, I don't know what we will ever do that, because we were all seeing the issues with the requirements in other states, and we are learning from those. So we are still in the Wild West of figuring this out. It's true. Jeremy Rudy says, once we know the role-specific competencies required for New Mexico, Saba Praxis can offer an alternative option for practicums and competencies assessments that wasn't available when Oregon and Colorado programs were stood up. While I think it's wise to have a reciprocity option for past training, we can directly verify proficiency through our all-powered simulation environment. Let's see.
And I think that said AI powered, but
that's okay. Eileen, let's see. Eileen says, but we don't know what that might look like right now. It's one of those things that was challenged in discussing with Lycos application. Further applications may not even tie the substance to PAT. And James Brown said, we need to ensure that there is continuation education for facilitators for each licensee renewal process. Yes. And we need to ensure that the program allows access to New Mexicans across the whole state for those who want to be trained. Okay. Let's see who has their hand next.
Looks like Ellen Schimmels. Oh, I do see Dominic has his hand raised. Dominic, is yours a quick tidbit or a tangent?
I will wait in turn.
Okay, cool.
So go on ahead to
all right,
Ellen.
so Ellen, I have enabled your mic.
Thanks. My name is Ellen Schimmels. I'm a nurse practitioner in Albuquerque, and I just wanted to kind of caveat on what I just said. I agree that we should definitely have reciprocity, but I think the best way to show that is to really look at a competency-based model. Things like BLS, like when you look at, you know, all of us medical providers get regular BLS, and BLS has already got an amazing model that we could be looking at using things like simulation, and I know what was mentioned, some of the AI driven and there's other platforms that are available that really we could take our learners into situations that are challenging, that they don't have the opportunity typically, that we don't want them to have the opportunity to have in the learning environment with either one another as patients or real patients in that capacity. I think that we have a chance to do something different here to make it a more affordable, because I know, you know, I've been through IPI, I've been through these medical trainings, and they're thousands and thousands of dollars. I don't know how we're going to afford that for training people here as well. So that does concern me, is looking at other routes that we could use technology, that we could use more competency based, where people are showing that they have the skill set if they've already, you know, that automatically puts that reciprocity there because they're showing they're competent in the things that they've already learned. And so I just think that we should, you know, I get standardization, but I think that it is not a one size fits all. To say that everyone needs 150 hours is silly. That's not how we educate these days. And we really need to look at competencies. Thanks.
Thank you for that. Yes. Well, I think when we're saying 150 hours or 120 hours, I think what we're saying there is for people who are just starting and want to get that education. I think the reciprocity part of it, I think having, you know, some hours that we have in our education for New Mexico would be an additional to what we've already been trained in. So I think adding that other part of it, once we get the training down, I think we'll be able to start to get this rolled out. But I think reinventing the wheel is not what we should be doing. Absolutely. Everybody's saying we have so many other things that we could pull into the training of document here that I think that we'll be able to probably get this together pretty soon, but we need to look at what the curriculum is going to be, and who's going to be doing the teaching, and who is going to be providing that. So yeah.
All right, Dominic, you should be good.
Yes, thank you, Johnny. And thank you, Brenda. And Ellen, thank you very much for some of the comments you just made. It actually dovetails very well in what I wanted to state at this point is I think everybody is starting to kind of jump ahead a little bit here, is what we need to be looking at is we need to be looking at competencies, at skills. We need to look at what licensures individuals already have. The statute is actually very clear that the practitioners or the providers need to be current licensed individuals in healthcare in New Mexico. And so one of the things that we're doing is we're actually cobbling together a list of all of those potential licensures that already exist here in New Mexico. Once we have that, we're going to be looking at different aspects of what types of training they already have, what types of training they may need in order to do work within psychedelic therapeutic environments, how that actually might work. We are also looking at curricula that are available through some of these other programs that have been approved by both Colorado and Oregon. And as we look at that, we need to be evaluating what parts and pieces are going to be appropriate for New Mexico, what parts and pieces may be a little bit too much and not necessarily needed. But we're not trying to sit there at this initial stage and try to limit by hours. When educational programs are developed, if people turn around and say something like, there's 150 hours that we need to complete for this program, what happens is instead of evaluating the actual needs of the education aspect of it, people try to then fit it in within that particular time frame. So what I would really suggest for right now is let's not talk about how many hours are needed or not needed. How many hours does Oregon do? How many hours does Colorado do? We need to look and evaluate. And to my knowledge, because I've been looking, and if somebody, especially some of those who are involved and have been involved in some of those programs in the other states, if there is an evaluation of the efficacy of the training program, I would love to see it. And I would love to be able to start looking at that. Many people that are on this call may not realize or know, because since I work at DOH and in public health, but my degrees and my education is actually in educational psychology. So developing this. So I've been listening to hear what people want, what's going to work for people, what people's needs are, so that we can help to shape this in a way that's going to be as beneficial as possible. So what we would like, though, is we want to ensure as we build this, we build it in a way that's going to acknowledge reciprocity issues. And for that, we do, as it's been said by a few people, we need to know what competencies we want to have with the providers here in New Mexico. What aspects do we need to do that are not included in any other programs that include specific items to New Mexico, including cultural, traditional, healing, and other areas? And how do we create that? So I wouldn't say we need to create a New Mexico module that'll be 6 to 8 hours or that side. While that can be a good start, we need to create a New Mexico module. And we've stated before, Department of Health will create that module with regard to folks that, as we determine, and as Brenda has said, we have not yet determined what those reciprocity qualifications will be, but we will create that and make that available to anybody who needs that. So that'll be whether it's individuals, training programs, or whomever, so that they can actually we can make sure that they understand the environment they're coming into, the populations in New Mexico, so that we can ensure that patients in New Mexico are getting not just patient-centered care, but New Mexico-centered care. And I think that's going to be a very important aspect. So as we look at all of this and as we discuss this, let's think about it from a standpoint of what is it that patients need? There may be programs that are out there that are going to align with that, or that they need a little bit of tweaking, a little bit of, extra support, or maybe even not as much. Because the other aspect that has come to us I can't even begin to say how much public comment and emails and messages is affordability. So many people, especially people in New Mexico, are not going to be able to afford a program that costs $8,000 to $15,000 in order to get training, especially if it's somebody who already has a therapist license, clinical social worker, etc. And so we need to make sure that we do this in a way that's going to acknowledge that and is as affordable as possible. Doesn't mean it's going to be free, but we want to try to make it so it's as affordable and accessible as possible. I've noticed some notes and we've gotten before as far as having things with virtual training. We do want to ensure that there's virtual training because we also have a lot of individuals who may be working out of frontier and rural areas, and they're going to be able to help those patients in those areas. If we mandate that it must be in person for an entire training program, that would be problematic. So we need to make sure there's that flexibility so that providers can actually do these programs, do them at their speed that's going to be appropriate, because how many of and for people who are on right now, how many of you currently have a different job? And so to be able to learn and do that facilitation, we need to think about things not just in person, but also asynchronous virtual, synchronous virtual, and James, I think, is the one who put it in about in-person practicums, that in-person to develop those interpersonal skills, which are going to be so key, will be very important for this. But how much time is that really going to take? We need to look at how do we evaluate that? And no matter what we do from the very beginning, one of the aspects we have to have is an evaluation component so that in a year, 2 years, we can adjust the training and the training requirements to meet what we find is actually effective. And so far, I haven't seen that with the other programs. So again, if somebody else has access to something like that and can share that, we would be happy to look at it. So that's really just all I had to say. I've been listening and trying to stay back so that people can talk, but I want to let everybody know we are hearing you. We are trying to figure out how to do this, and we are taking the time. Yes, we do not have a lot of time for December, but that's a part of where the reciprocity comes in. And will we always get everything right? Probably not. But I can tell you right now, and I already know, in knowing several of the people that are here already, we have some fantastic facilitators already present in the state. And that's how this program is going to start in December, because we already have a fair amount of these skills and these abilities resident here right now. Anyway, I'm going to shut up right now. And let everybody continue to talk. So thank you, everybody. And the conversation is great to have. So please continue.
Thank you, Dominic, for that, because I think that was kind of in everybody's mind. It's like, okay, how is this going to, how are people going to afford this? And that was in my last slide, actually. I had like cost, training, and licensure and all of that. And I kind of, well, maybe Dominic's going to come in here and say something, because I wanted to kind of leave this open, because I think talking about all of these different things that are coming into the education and training, I think the competency is really something that maybe we can work on in our next meeting and see what that's going to look like as far as what the training's going to be. So, thanks for jumping in like you did.
All right. Let's see. I think next with their hand up, we've got Lisa Ginsburg again. Lisa, I have enabled your mic.
Thank you. And I just wanted to build on Dominic just said, having a mixture of virtual and self-paced content for didactic education is, I think, totally feasible. And that's how we usually have our training designed in Colorado and Oregon. And we see a lot of success with that. I think also the highlight for the in-person and human-to-human skill is really crucial for the practicum. And what we observe that sometimes when people actually in a real physical space you deal not only with personalities, but also with energies of the people. And that significantly changes the environment. And it's something that I think really important to keep in mind and have that human component as well, that unfortunately at the moment, artificial intelligence cannot replace. And I think that's something that should be preserved and celebrated, that we have different personalities and energies, and the in-person practicum is really important for practitioners, regardless if they have years of psychiatry, psychology experience. It's very different for psychedelics. Thank you.
Absolutely. Thank you, Lisa. That's so true. I mean, when you're working with a client, you have to be present and you have to know how to work with that client, and doing that in person is vital. This is a we can't be replaced by machines to do that. This is a very human interactive. You have to be very empathetic. You have to tune into the client. You have to see what the client's needs are, even if they are having a difficult time going through the journey. So there is that practicum piece that's so very important. And especially if we do roll out the program where, let's say we do have 120 hours of from start to finish for those who do not have any experience with psychedelics in a medical clinical way. They're learning this. Practicum is one of the key things that experiential type of education. You can't get that from reading a book. You have to be present with the patients. Absolutely. So anybody else have any comments?
I don't see any hands raised right now, but James Brown just posted in the comments idea on NM specific modules for the core training and for the reciprocity training, ICD-10 codes and billing of insurance specific to the program, safety to include personal bias, New Mexico treatment conditions, and New Mexico specific practicum settings.
Yeah, I think the ICD codes are very, very important. And I don't, I've been attending a lot of these meetings and we don't know right now what that looks like. And especially with Medicaid and Medicare, because we are one of the poorest states in the nation, for practitioners like myself, the majority of my clients are Medicaid and Medicare. So if the insurance companies miraculously say, okay, psychedelic therapy will have its own code, great. But I think for right now, I think a lot of people are just, who are underground, are just, if they are doing billing hours, they're just billing it as a regular therapy session. But it needs to have its own specific code in order for insurance companies to have this. So yeah, the other thing too is safety. A personal bias, yes, absolutely. And this is done in training. If a clinician has a personal bias, the thing to do is to refer them to another clinician that can. As far as treatments and conditions go, yeah, that needs to be, we need to have a standard there. What is the treatment going to be? We have to have a set type of way of doing this, and doing it in a very respectful and client-centered way of doing this. Yes, a lot of us clinicians and nurses and us in the medical field are trained in that, but yeah, psychedelics is different because it is more it is more intimate than just regular talk therapy, for instance. There's elements to psychedelic therapy that are almost hard to describe. The relationship between the provider and the patient. You are there on their journey, and you are taking care of them in a very different way than, say, just giving them a pill and talking about their issues. This is going to be paramount to practicum. And the other thing, that leads me into the practicum settings. Where will this be done? And that's always been one of my biggest questions. Where will it be done? Will it be done in a hospital setting? Will it be done in a clinic? I've heard people saying that it's difficult to do it in people's homes. However, if there's death and dying, they can't make it to, a center, for instance. So what is that going to look like? What is the environment going to look like? What are people going to feel comfortable with? Remember, this is the medical model, and to have ceremony with it, why not? Why not have someone come in and provide ceremony for someone who, for instance, is dying? So there's a lot that we really need to think about as far as these topics go. I think creating a real robust way of training people in different settings, in different types of circumstances. For instance, if someone is dealing with chronic pain, it's going to be different from dealing with someone who is having issues with anxiety and depression. So, James, anybody else have any comments at this point? Well, if you, I just want a show of hands of people who have read this document. Okay, I can go ahead and read through this document, which probably was something I should have done in the beginning. This document, I think, yeah, we need to post this. So we only have, I guess, about 20 minutes or so. I could go ahead and read through this document if you like, and I should have done that. Pardon me, I really apologize for that. Let me read through this document, and then we can post it, I think, on the site.
We will. Yes, we will post it again with the minutes and also the video.
Okay. Do you think we have time to read it, or should we just post it, Dominic?
Brenda, that's what I was going to suggest, is to let people do that. It is actually on the site already, and I'm going to put it here in the chat. So just so that everybody is aware, we do put the documents for various meetings. There is, it's on the web page, and I'm going to put that in as well. And so that is under, if you don't see that under the direct link there, it is under the 2026 tab for the Medical Psilocybin Committee meeting records. And it was on January 23rd when we had the last meeting. And you can see the recording, the presentation, this document, and then there was a training requirements and qualitative analysis from HAF that they had submitted as part of the public record. And all of that is there on that page with that direct link. So what I would suggest, since there's just about 20 minutes to the end of the meeting, is for people to read through it, to go to it, read through it for the next meeting. just because otherwise I don't think you'd have enough time, Brenda, to even read through. So,
well, the next time I think I will go ahead and read through it again, because if anybody needs to make any changes there, do you think that's appropriate for next time?
yeah, I think going through section by section like we had done would be a good way to do it, so people could highlight and understand and answer specific to those sections rather than trying to go through all of it all at once. And so I would say go through section by section.
Okay, all right, thank you. It was one of those things where I for the second meeting, I just wanted to do something a little different. And I'm glad because I got different results this time, and which was really, I think people really needed to talk about all of this, and I'm grateful for the people that were from Oregon and Colorado, people that have already done a lot of training. I'm really grateful for all of your input here today. It's been amazing, and it's eye-opening and very refreshing to have all of these comments come in about formulating what we need to do for our education here in New Mexico. So I want to thank every one of you for being here today and your comments.
And Brenda, what I would also like to say is just because I've gotten a couple of emails from individuals that they send them just to me. And what I would actually suggest is if you have public comment or potential resources, not to send them directly to just me. Quite frankly, I get overwhelmed with emails sometimes, as I'm sure some others do. But we do have multiple people who look at our medical psilocybin email. And so I'm going to put up the information, what needs to be done as far as for, and Jorge actually did it while I was talking, for how to send in public comment. But also if you have resources, just remember, please keep it limited. Because otherwise what ends up happening, and it has happened, is we quite literally get thousands of pages and we're not able to read through that much. We need it specified, reduced down to what are you looking at? What do you want us to look at? A little bit of a summary, and really making sure that it's brief and short. And so the email, if you sent something, please resend it to that main email, because again, we do have different staff who are helping with different aspects and different pieces. And so they'll be able to take that, look at it. If it's something for public comment, we'll put it in the public comment. If it's just for our information, we'll be able to to pull that on out and look at that as separately. So but thank you, everybody. And thank you for posting that, Jorge.
Thank you, Dominic, for that too. And I wanted to let a lot of people know, because a lot of people have my email as well, that if you do have a comment, this is public. So you need to bring it publicly, because I'm not going to go in there and start changing the document. This is a public document. So if you have any ideas or you need to change anything, please come to the meetings and change it we'll change it in these meetings. But I'm not comfortable with changing anything in this document unless it's public. Okay, anybody have any other comments or would like to say anything at this moment? Okay, Dominic, do you think it's proper to end the meeting at this point?
I think so. The only thing I would say is for the next meeting.
For the next meeting. Okay. So the next meeting will be April 10th from 1 to 3 for the education and training for the medical psilocybin program. Please bring your comments and any notes that you have or any information you want to bring in. This was a wonderful meeting. I want to thank every one of you. This is wonderful. And I know how hard it is on a Friday to take time from your regular jobs to come and sit at these meetings. And it is hard to pull away, but it's so very important. And I love all of your enthusiasm with this, especially people. I want to say thank you to everyone outside of New Mexico coming here and giving your wealth of information to us, because we are really starting to make this happen here. So thank you, everyone. Thank you. And thank you, Jorge. Thank you so much for doing everything. You're very wonderful. Thank you. And thank you, Dominic.
Thank you to everybody. Thank you, Brenda, so much for chairing the meeting. And we look forward to the next one.